Thank you so much. I am humbled by being here. I actually don't feel worthy to be talking about this topic, but here I am. I also thought I had slides that I could send this morning, and that didn't work out, so I'm just going to read from this and go along so I don't miss anything. Well, I was charged with looking at global poverty. And when we look at global poverty, the first thing that I think of as a public health person is the first iteration was the Millennium Development Goals from the year 2000 to 2015, which the focus was on poverty and addressing global poverty. It was primarily related to the low-income and middle-income countries. And actually, we did see some benefits to that. As of 2015, only 14% of the world was living in extreme poverty, which at this point is $1.90 a day. Since that time, and this really is an important thing that for you all to think about, we have the Sustainable Development Goals. So you students, how many of you have heard of that? Okay, law professors, you have work to do because these are global goals that influence all of us. And the very first goal is poverty. And so we're hearing today of how the intersection of both poverty, education, healthcare access, all the isms of racism, ageism, all of those things come together. And these 17 goals address those things as well as climate change. And we're hearing how they come together. So that is extraordinarily important for us to think about and use as frameworks. So I recommend everybody, and even people outside of academia, those of you who are in service and in industry, the healthcare industry, you should be looking at this and considering all of these factors that influence human health. Currently, there are close to, well, actually, this figure is from 2019, so we know that it's actually worse now than it was. But as of 2019, there was close to 700 million people living in extreme poverty. COVID-19 has definitely turned the tables much more challenging for people. So we have more people in extreme poverty. I just don't have those data yet. That is not available to us. But when we think about global poverty, it is many of the things that we have heard today. Again, as I said about the influence of education, the influence of access to healthcare for everyone, the people living in remote villages, on mountainsides where Father Art is, where he worked. They should have the same access. The people that need housing, all of those issues influence global poverty. We've also heard today repeatedly of where we live matters, and I almost did a cartwheel to hear Secretary Castro refer to these social determinants of health. They affect all of us, and they affect us here as well as the most remote corners of the world. If you don't know what that means, Google it. But what you need to know is that all of these things, the way we live, either keeps us well or makes us sick. And so I've heard people talk about COVID-19 and the number of deaths and associated it with race, and that's true. But it is a long-term period of people being exposed to discrimination, people being exposed to not having those educational opportunities, not having the ability to earn a fair income around the world, wears on our bodies and causes things like early cardiovascular disease and early onset diabetes. So they're the things that we need to address, and I've heard the importance of that, and we need to address it not only here, but around the world. And the last thing, well, two things that I want to, well, three things, forgive me, I'm a teacher, we could talk forever. But COVID-19, we saw the influence of poverty. And we saw the influence of how we're all in this together, right? Our worst nightmare was an airborne virus. Well, we got it. And so we have seen with that what has happened in the United States for low-income communities and around the world. And one of our earlier speakers talked about, and Father Art also talked about charity and donations. That is not the way to go, but that's what we saw in this epidemic or pandemic for low-income countries. So they were relying on our goodwill if we had it, but what initially happened is we all kind of looked inward and started taking care of ourselves. And that also played a role in vaccinations. We have seen that many low and middle income countries don't have the same level of vaccination that we have. Well, guess what? If they don't, it affects us, because we've seen that with all the variants, right? The Delta variant. So it is really important that we get it to everyone. So I want to have a disclaimer. First of all, I know I'm in a law school. So I'm going to make a statement. I'm not making a recommendation on medications for anybody, okay? This is from, but I just want to say that because I know how you lawyers get. But the WHO statement on the booster, I want to read this to you. National vaccination program policy decisions to add a booster dose should take into account the strength of evidence regarding the need for these doses, their safety and effectiveness, as well as global availability of vaccines. Offering booster doses to a large portion of a population when many have not yet even received a first dose undermines the principle of national and global equity. I'll also add it undermines the principle of global health security. So these, I'm not saying no, get the booster. I'm not making any recommendations. I'm reading what was said. But it is something we really need to consider if we're thinking about getting out of this. Oh, now I enlarged that. Now I can't move. So it is important that we understand that we have a highly infectious disease that doesn't care about our international borders. And if we don't stop it everywhere, we're not going to stop it. And then lastly, I want to highlight again, my area of research is climate change. And we see the impacts on our low and middle income countries related to climate change too. And they are not the people that have, for the most part, caused this issue that we're in. And so when we think about those most vulnerable to poverty, we need to, it tends to be the same group, right? It tends to be people that don't have access to education, don't have access to healthcare, don't have the agency that many of us are fortunate to have. And so, and that is the same group that is bearing the brunt of COVID-19 and certainly of climate change. And in my own work, and this is an editorial I have in my head that I'm probably gonna write next week when I go out to Denver, but I really see COVID-19 was a dress rehearsal for the challenges of climate change. And so we do need to think about how we're going to do things differently. And so thank you all for doing this work, and I will pass this on to our next panelist.
All right, so we can skip over this one pretty quick. This is me. It's basically what I've done since law school. I went to Drexel, go Dragons. So the great Angela Davis just advised us to focus on institutions and structures. So that's what I'm going to do in the healthcare context. We have very talented people who've spoken before me and are going to speak after me. They're going to share their perspectives from an individual level, from a professional level, personal, all that stuff. I'm going to speak at the systemic perspective level because that is where I've done most of my work, and to be frank, that's the most interesting perspective I can share with you guys. So, oh, shoot, I went too fast. All right, I'm relying on all of your background knowledge on poverty and healthcare and how they interact in order to connect the dots because just don't have time to connect all of those and you don't want to listen to me do it. One note on terminology, I'm going to use healthcare with a space generally refers to care. Healthcare without a space refers to the system of healthcare. I use no space throughout, even though that's not exactly correct. I don't want it to distract you. I just did it for consistency's sake. If we're talking about care, it should have a space in it. And now down to the actual presentation. So the next slide is a timely example of how poverty and healthcare interact in how they affect every single one of us. So vaccination rates are a great proxy for the health of the public because they have a clear and direct connection with not just the folks who have not yet been vaccinated, but everyone they come in contact with. The point of this being that Americans who are uninsured are a societal problem and representative of a larger problem of our accidental and broken healthcare system. I figured I'd start off the 2 trivia questions with an easy one. Please don't shout it out because I have some sweet pictures coming up. That kind of gives it away. I had to include this picture even though it's not the clearest because it's like a Renaissance painting. I'm not sure if this actually happened or if it's a genuine rally, but I just loved it so much I had to include it. And I think you get the point now. It's universal health care. Everybody is covered in most developed nations, all developed nations other than the United States, through a universal health care system. Canada does it different from Germany. Britain does it different from both. It's the same impact. Yes, 11% of people in Britain have private insurance on top of their state-provided universal health care. They have a baseline similar to what Secretary Castro was talking about earlier with the water baseline in San Antonio. Universal health care provides a baseline in all developed nations but our own. Now that you're all warmed up with the easy one, here's a little bit of a tougher one. What is the only state that has attempted to create a universal health care system in that state? Here's a hint. For those of you who know your state houses, the gold dome, not the green dome. Vermont. Romney Care in Mass was not quite universal. It was a bridge there. So this gets into the real nitty-gritty. For a 3-year period from 2011 to 2014, my home state, where I was fortunate to grow up, of brave little state of Vermont, actually gave universal health care a shot. The rest of my talk, and it will be brief, is a very high-level breakdown of why that first-of-its-kind effort was unsuccessful and what future healthcare reformers can learn from Vermont's failure. So this slide is an important high-level background on the universal health care law. It was technically Act 48, but you don't need to know that. It was passed in 2011, and it generated the kind of headlines you saw before from the great Sarah Cliff. Vermont's trying, someone's trying to be Saskatchewan in the United States. Sorry, this is blurry. It was the best one I could get. So now we get into the numbers. The pie chart on the left shows how healthcare was actually paid for in 2017. The pie chart on the right shows how it would have been paid for if universal healthcare had come to fruition in my home state. The important thing to look at here, on the left, you don't see the acronym GMC, Green Mountain Care. On the right, it consists of about 2/3 of the sadly hypothetical spending that would have taken place if the transition had been successful. On the left, you have the Medicaid and CHIP piece of the pie chart. Vermont pays for about 45%. The feds pay for about 55% of the Medicaid program in Vermont. So you can basically say that half of that 28% was state paid for. So the shift from the left, reality, to the envisioned, hoped for, and not quite gotten to future on the right is approximately a quintupling of state revenue dedicated to healthcare in the state of Vermont if things had come to fruition. I call it the big shift. Feel free to steal that. So this slide and the pie charts before it give you a pretty clear picture as to why the governor and the legislature punted on the pay-fors when the Green Mountain Care was created by law in 2011. If you missed that in the last slide, I'll go back. The bottom bullet, the kind of key point there, the law creating universal health care, or trying to create it, did a lot of great things. What it didn't do was create new pay-fors or set targets for the healthcare court, which actually still exists, and my Little League coach is one of the 5 board members. It's a tiny state. So that's what didn't happen. This is, you can argue they should have done it. It's easy in hindsight. This is kind of a hindsight presentation, but that's what didn't happen. This is the big shift. That was the big shift in revenue. And here's the sticker shock. Now, what's going on here is in part Vermont's inherent weaknesses. It's a great state to grow up. It's not a huge economic power. But that's only a small part of it. The larger part of it, the larger point, is Vermont's structural weaknesses were only a minor causal factor here. The driving force behind that massive new revenue need you see on the screen up there was a lack of any meaningful cost control going back decades. So this is healthcare costs in the state of Vermont. You see no break in the upward trend. It keeps going like that. I'm sure if this went back to 1990, you'd see the same trend. It started around the 80s, late 80s, depending on the state, but solid 4 to 7% growth per year. I say solid, not in a complimentary fashion, just to mean consistent. So now I'm sure some of you might be thinking, this guy's trying to tell us that change of this scale is just hopeless. And if there's one thing I want you to take home from this presentation is that that is not the case. There are policy choices that my home state and that every state in the union failed to do enough on, but other states or the federal government could get right in the future. What you're looking at right here is the single biggest conglomeration, excuse the word, of policy choices. This is not an accident. This is mostly omissions, but it's not an accident. So what are the key takeaways here? I realize this is a big subject. Boiling it down to 3 key takeaways seems like an oversimplification and overdistillation. You're correct, it is. But you're gonna walk out of here and remember something from this presentation, I hope. These are the 3 things that I hope you take away. Shifting from the multiple payers in the fragmented payer landscape that we have today to one payer, or really it's Medicare, the federal government, and a state, is a really heavy lift. Managing that shift requires a meaningful transition period. I didn't talk about transition periods because I didn't want you to fall asleep. Trust me on that one. Number 3, and if there's one thing I hope you remember, it's that cost control is critical. You see this chart. This is why healthcare didn't become universal in my home state. And this is what any state or the federal government in the future needs to focus on in order to make it a reality in the future. Now, I'm not here to just tell you guys about how to make universal health care. The point is, if we want folks to get out of poverty, if we want people to have better lives than their parents, to stop the widening inequality gap in this country, everyone needs health care, and this is what we need to focus on to make that happen in the future.
Hello, everyone. Is the post-lunch nap time setting in? I'm gonna try and keep everybody up. Good afternoon. Thank you for having me. It's wonderful to be here. I'd like to thank my friend and my mentor, Professor Stephanie Senna, for inviting me to share some of my story with you today. It's really an honor to participate, so thank you so much. I'm very grateful to be here. So I'm here to talk to you a little bit about Philly, our beautiful city of Philadelphia. For context, I'm not a Philly native myself. I'm from North Jersey, which is, as everyone knows, a whole other world. But I've been living and working in the city for a little over 5 years. I am a registered nurse, and I study nursing here at Villanova. Go Cats! Thank you so much. So when I graduated, I looked for work locally in some of the same health systems where I had clinical rotations. I got my first job at a hospital called Hahnemann University Hospital on the inpatient oncology and bone marrow transplant unit. I didn't know it at the time, but I was very, very lucky to start my career there. Hahnemann was a Philly legend, a hospital that stood in the center of the city for over 150 years. It had been serving Philadelphians since before the Civil War. It towered 20 whole floors over Broad Street. It was a really ugly, gray cement building with unwashed windows, very serious and imposing, and I loved it there. Compared to the newer and the shinier hospitals nearby, Hahnemann had a reputation for being a little bit on the rundown side. And it had this reputation for many decades before I started working there. With such a long history in the city, independent from the large health systems that dominate the greater Philadelphia area, it comes as no surprise that the hospital changed hands many, many, many times over the years. Hahnemann and its sister facility, which is called St. Christopher's Hospital for Children, had been the property of the Allegheny Health and Education Research Foundation since 1993. And at that time, Allegheny was the biggest health system and the best incorporated one in the entire state of Pennsylvania. But in 1998, Allegheny filed for Chapter 11 bankruptcy and agreed to sell Hahnemann and St. Chris to another healthcare corporation called Tenet, which is based out of Texas. Allegheny collapsed completely, and its record-breaking filing of $1.3 billion remains the largest healthcare bankruptcy in the history of the United States. And their successors still owned Hahnemann by the time that I started in the year of 2016. I think it's important to note here that there are no public hospitals in the city of Philadelphia at all. It's the largest US city that doesn't have a public hospital. It's the 6th largest US city overall. And following the closure of Philadelphia General Hospital in 1977, Hahnemann was sort of thought of as the only thing remotely comparable to a public hospital left in the metropolitan area. Especially to those with limited or no insurance, those relying on Medicare and Medicaid, migrants, people experiencing homelessness, the LGBTQ+ community, and folks with chronic health conditions and disabilities. Sitting on the edge of North Philly, Hahnemann served mostly residents of the surrounding neighborhoods, many of whom lived in poverty and who were uninsured or underinsured. About 2/3 of our patients were people of color, many of whom sought services at Hahnemann because it was the closest hospital accessible on foot, by bus, or by subway. And when I interviewed there in 2016, I heard the same thing from all of the nurses I spoke to. It's a great place to learn. It's a hard place to stay. You'll learn a lot. We're still here because we know we're needed. It turned out that that was a common thread among Hahnemann employees. Many of us felt like we were serving our calling there. I know I did. Despite the allure of other jobs in this city, it was as rundown as it looked. And it was old, but it was our hospital and we were there for our patients. In a way, it made sense and it scratched the itch. We were needed. It was the perfect place for me to start my career. I was extremely painfully green, but really hungry for experience, desperate for patient contact, traits of every Nova nurse. I learned quickly from my colleagues and also from my patients that Hahnemann really was a special place, one where I would learn a lot in the first few years of my practice. We were partnered with the Drexel University College of Medicine, and the hospital, despite really looking worse for wear, housed this massive academic institution full of brilliant researchers, talented clinicians, many of whom were really working on the cutting edge of their discipline. In fact, still a point of pride, Hahnemann boasted the 2nd Gender Affirmation Surgery Fellowship ever established in the US, and one of the finest kidney transplant programs in the world. With over 500 resident placements, Drexel's residency program at Hahnemann was one of the largest in the country at the time, and it was a magnet-designated center for nursing excellence, plus a level 1 trauma center, all of which is to say that we were providing high-quality, complex care, comparable to the highest-performing hospitals in this country. I worked on the 15th floor of the North Tower, right next to the helipad. treating mostly oncology patients. We prided ourselves on doing it all, which is a rarity in oncology today. We would treat blood cancers, solid cancers, we would transplant stem cells, admit and discharge chemotherapy patients in one day. It was a really busy unit, just like the rest of the hospital, starved for supplies, short on staff, but busy and proudly busy, unwilling to compromise on care. And it became a point of pride for us nurses that we could do more with less. About a month after I started working, we 800 Hahnemann nurses unionized to present a stronger front for staff and patient advocacy. And to my surprise, I was elected to the union board. I hoped my voice, again, 1 month into my tenure, so that's how things go. I hoped my voice would help us win improved staffing ratios and some new equipment, which we desperately needed, plus maybe a chance to inspire in our owners the pride that I felt as a nurse working at Hahnemann. And though we worked really hard to restore accountability to our owners at Tenet, I did my personal best to ignore the peeling paint and the broken furniture because someone else had been there doing my job since 1848, and our patients still needed us to show up every day. There was no option, there was never any option, but to continue doing more with less. According to the Pennsylvania Department of Health, Hahnemann had 56,725 emergency department visits in the year 2018, ranking us that year the 8th busiest ER in Philadelphia County. Our 496 beds were frequently full, but we were always hearing rumors about increasing costs, declining revenue, and it was common knowledge that Tenet planned to sell both Hahnemann and St. Chris as soon as it was feasible. In 2018, Hahnemann represented 7.5% of the state's Medicare and Medicaid utilization, putting us in 3rd place overall, surpassed only by Temple University Hospital and Einstein Medical Center, our fellow North Philly hospitals. Like the other hospitals serving Philly's most vulnerable, Hahnemann earned the bulk of its reimbursement from Medicare and Medicaid on reimbursement rates about half of those offered by private payers. Without a more robust payer mix and the higher reimbursement provided by private insurance companies, Hahnemann had always struggled financially. The staff that had been there since the days of Allegheny, way back in the 90s, remembered the bankruptcy well in 1998, and they reminded those of us who were newer that Hahnemann had been in the red for 100 years, literally. And it had always been a poor moneymaker for its owners. I believed, as did most of my colleagues, that we were too important to go anywhere. It seemed inevitable that things would change, and they did, but for the worse. When we were sold again, this time by Tenet Healthcare, to a private equity firm called American Academic Health System. And American Academic described itself as a business with a fondness for rehabilitating underperforming facilities. That's what we were told when the sale was finalized in September of 2018. It was run by a man named Joel Friedman, an investment banker with some experience in healthcare management. I remember in that first week we got a new fax machine. And I also remember thinking we didn't have enough linens to change everyone's beds. So the fax machine was working fine, but weren't we gonna get a better linen budget? As the months passed in 2019, things got tighter and tighter very quickly. Our EKG machine broke down. I know. Our EKG machine broke down, and it didn't get replaced. One week we ran out of cups and straws for patients to drink out of. I took a crisis call on the union phone from a friend on the labor and delivery unit. Mid-shift one day, they ran out of fetal monitoring equipment, and the hospital didn't order more. The air conditioning gave out. That summer it was 86 degrees in the NICU. Vendors stopped visiting the hospital because we weren't paying their bills, and eventually we ran completely out of some of our linens. On night shift, we used to pile up blankets in the nurse's station and cut them into washcloths for bath time. Things became dire really fast. It was a brand new, terrifying level of cutting back and having less. As chief executive, Joel Friedman closed 3 primary care offices to save on operating costs, and then in April, he laid off 175 staff from Hahnemann, including some of my nursing friends from the 15th floor. He made public statements that Hahnemann was financially unsalvageable, which was a new word for us. Without serious help from the government, he said, we would be closed in a few months. And in May, Despite pressure from my union, from City Council, and our physician partners at Drexel, Joel maintained that the hospital's closure was imminent. There was nothing worth doing. My patients, if possible, were even more panicked than we were. They scrambled to get their medical records in order, and they worried over chemo and radiation scheduling at other hospitals. The unionized staff at Hahnemann held pickets and protests on Broad Street, pleading with the media and with city officials to help stave off the looming closure in court, or at least buy us enough time to find a new buyer for the hospital. We'd been rescued before. Bernie Sanders held a Broad Street rally in favor of keeping the hospital open while campaigning for his presidential election. And we felt like we were all screaming the same thing: help us. We want to stay. We're needed here. Despite our best efforts, the official announcement came on June 26, 2019. Joel would close Hahnemann permanently that September. With the announcement came a staged closure plan, and within a week, our hospital census dropped from 450 patients to 80. We lost our trauma designation almost immediately, an injury that was unrecoverable. Due to lack of resources, it was impossible for us to take critically ill patients anymore. We couldn't receive referrals through the emergency department or off of the helipad that I love so much. The emergency department was completely closed down by July 3rd. I remember because that day there was an accident on Broad Street, right in front of the hospital. A woman was clipped by a car crossing the street and she collapsed on the curb. Some Hahnemann employees rushed out to help her, and they called 911. Without a functioning ER, we couldn't do anything to treat her at Hahnemann. An ambulance pulled up in our ambulance bay and bundled her up and drove her a mile up the road to Jefferson. I was terminated in August. There were no patients left to treat. Suddenly, I was the one with no health insurance and no income, and the empathy I used to have for my patients took on an entirely new meaning. More than 2,000 providers, nurses, and staff lost their jobs that summer. 572 resident physicians were displaced due to the disclosure. Some of these residents were in their first year of training, and it's the largest number of residents ever displaced in recorded history. So what's the point? It's depressing, right? When private equity gets involved in the sale and management of hospitals, the patients are the ones who pay the cost for changing things up. When private equity stands to strip a facility for parts, shutter it, and profit off of the block that it was built on, the patients pay the cost. Hahnemann occupied land that made very little money for providing the essential services it provided. It would stand to make much more as a luxury apartment building or a hotel complex. We found out after the fact that when Joel brokered the purchase of Hahnemann for American Academic, he negotiated a deal, placing the real estate that the hospital was built on in the hands of holding companies, far from the reaches of bankruptcy court. Separate from the business of running the hospital, too. Isn't that convenient? The buildings remain empty today with the lights on, but the block they sit on is waiting to be developed for a massive profit. Some Philly developers estimate that it's worth over $100 million. This is how a hospital that survives a $1.3 billion bankruptcy in the 90s ends up folding 20 years later. It's intended to. In the US, we see 30 hospital closures roughly per year. Hospitals that are sold to private equity firms, and each one has a network of people that rely on it, both patients and employees. In 1997, there were 18 labor and delivery units serving the city of Philadelphia. Today, there are 5. The 6th was in Hahnemann University Hospital. Forget for a minute the people who lose their jobs. Think about the patients who suffer from lack of access to health care. In Philly, we can't afford to lose a level 1 trauma center. No US city can. We can't afford to lose a hospital that sits on top of a subway line. We can't afford to lose an emergency department or a labor and delivery unit or an inpatient behavioral health center. We absolutely can't afford to lose a 496-bed academic medical center 6 months before the worst global health crisis in modern history. When we punch holes in an already burdened safety net, people fall through. My patients, mine, have sickened and died and gotten hurt without us being there to care for them. And we will never really know the full impact of losing Hahnemann, but we do know that the city suffers for it every day. Those 56,725 annual emergency department visits still need to be seen, but they go farther and they wait longer than they used to. And when you're having a heart attack or a stroke or laboring with a baby, those minutes add up fast. After Hahnemann closed, the ER wait times at Jefferson, just 1 mile away, increased by 20%. 2 weeks ago, an old patient of mine reached out to me to let me know that her cancer is back. And that news cuts me deep. I can't help but wish that I had the chance to treat her again, that if she came back to the 15th floor, we'd still be waiting for her to help, like we promised we would be the first time. Healthcare is an essential human right. I'm not the first person to say that today. It's also a personal, intimate link among people needing care and people providing it. As a community, we have to insist that patients come before profits every single time. Let my story of the hospital on Broad Street, the one that stands empty with the lights on, even today, be a warning that even with peeling paint and unwashed windows, we have a tremendous amount to lose in losses like this. Investors who take a personal stake in hospitals are wagering their money. But when we privatize healthcare so willingly in the hands of private equity, we are the ones wagering our lives. Healthcare may be a business, but as a public, it's our job to keep venture capitalists out of it. Thank you so much for listening. And if I can leave you with one other sentiment, take it from the ICU nurse before you. Your COVID vaccine and your flu vaccine will save your life. And if you need help figuring out where to get one, come find me afterwards. Thank you.
Good afternoon, everyone. This has been one of the more powerful events I've been to, so thank you, Stephanie. And I'm not sure why I'm here, other than I've been trying to, in the context of the sustainability, the Millennium goals of the UN, to push the university to, I'm on a team that's trying to get full healthcare coverage for our graduate students. So maybe that's why I was asked. But anyway, so I welcome this opportunity to be on this panel, and my goal today, our goal, Jennifer and I, is to illustrate the challenges and opportunities around healthcare by focusing on the experience of graduate students here at Villanova. There are about 4,000 graduate students here. We have MBA students, law students, engineering students pursuing terminal degrees, either at the master's or doctoral level. And then, of course, we have graduate students in the College of Liberal Arts and Sciences, which is where I find a home. And they are pursuing master's and doctoral degrees. Some graduate students at Villanova are fully employed, pursuing their graduate degrees part-time. Other students are stipended via the university, either through a graduate assistantship or research assistantship. So later on, I'm going to refer to them as financially dependent. All I mean is that their primary source of income is the university. In fact, according to the rules, their only source of income. Among graduate students, my understanding is that only the law students and the international students are required to have health care. Unlike the undergrads who must have health care. So now I'm learning a lot here, so if I'm wrong, I'm sure Jennifer can correct me. But some of the graduate students have it through their employers, obviously, if they're employed, and others benefit from the ACA, the Affordable Care Act, or they're on their parents' plans if they're younger than 26. And in fact, we have grad students who transition from being on their parents' plan to having to find their own, and they have no idea how to do that. And there's no apparent support to navigate that. Financially dependent graduate students receive a stipend from the university to use toward health insurance. That stipend, as you'll see shortly, is not sufficient to meet the need, and there is a great need among some of our graduate students. They have pre-existing conditions. Some start families while graduate students. Some develop health conditions while graduate students. And that was all exacerbated during the pandemic, especially for the graduate students who must interact with students in labs or classrooms as part of their assistantship. While, of course, the university put in place precautions against the spread of the virus, no system is perfect, as we all know. So given the less than full coverage of healthcare insurance costs, graduate students must dip into their already insufficient graduate stipends. They must take on more debt, and some go without food. Now, Villanova is not unique in that regard, but as Father Art alluded to earlier, and Father Peter said quite clearly, we do espouse values that push us to do better than what we're doing right now. To specify the challenges of that situation I'm gonna interview Jennifer here, who is a 6-year graduate student in the philosophy department, and ask her to give us a little bit more specific context to this situation. Okay, so Jennifer, can you help us understand a bit more the situation for graduate students?
Okay, yes. First of all, thank you, Stephanie, for giving us this opportunity. This is like my millionth time thanking her, and I'll probably thank her again in the future. But like Auntie, who spoke earlier, I'm here to speak in truth and love and also hope, and more specifically to represent the graduate students at Villanova who are financially dependent on the university. So at Villanova, graduate students not only study, but we teach. I'm teaching Philosophy 1000 right now. We also work in labs, teach labs, assist professors in the classroom, and mentor undergraduate students. Funded doctoral students make about $27,000 before taxes over the course of 9 months. Students adjuncting and master's students make significantly less than that amount. Some students also have summer funding, but most do not. Most assistantships, like Mark said earlier, don't allow students to take on outside work, and the logic there being that taking on extra work means you have less time to devote to your studies, and that extends your time to completion. So given the high cost of living in the area surrounding Villanova, and also the area most easily accessible in Philadelphia, and of course the recent spike in the cost of housing, students live on a shoestring budget, and this is reflected in how many of us are woefully underinsured or even uninsured, even with Villanova's $1,500 healthcare subsidy. Since 2016, doctoral students have been surveying, some people, my supporters are messaging me and disrupting, so please stop doing that. Thank you. Okay, since 2016, doctoral students have been surveying other students about their health and healthcare situations. In 2020, so right in the middle of the pandemic, when we surveyed students, 38% of those who responded said that they were not adequately insured and pointed to their high healthcare deductibles, upwards of $9,000, as one important reason for that assessment. And remember, we make $27,000 over 9 months. We also saw an increase in the percentage of uninsured students year over year, from 7% in 2019 to 11% in 2020, even as the number of students we surveyed expanded. The well-documented instability of prices on the national healthcare marketplace is one explanation for that worrying trend. Students may also have debt, financial obligations to family, or even dependents themselves, which disallow them from spending their salary on health insurance. Some broad conclusions we drew from the surveys are ones that have been reported year after year. Students cannot afford to be adequately insured. The healthcare that we can afford is not adequate, and adequate healthcare is not affordable. As a result, without access to adequate healthcare, students have experienced immense difficulties finishing their programs, have left their programs, have opted out of teaching, which is critical training if you want to be a professor in the future, for better paying jobs with healthcare, taken on massive medical debt, or delayed, even foregone medical treatment altogether with life-threatening consequences.
All right, thank you. So I hope that gave you a sense of the financial situation that people find themselves in. But those statistics, although important, are not as important as the faces and the actual stories. So Jennifer, can you tell us a little bit about the stories you've heard?
Yes, and I realize that a lot of what I'm saying might discourage the undergraduates in our audience from applying to grad school, but I'm going to have to say it anyway because it's just the truth. Okay. So I'd like to reiterate Stephanie's, Professor Senna's comments from other events that we've had with her, that the actual faces of those suffering from poverty do not always coincide with the ones that we typically imagine. And I hope to give some flesh to those faces right here on our own campus and to make their struggles vivid to you, especially as many of these students feel a sense of shame and, guilt for speaking out about the ways in which they struggle financially, emotionally, psychologically, and physically during their time at Villanova, exacerbated by the fact that this is an amazing institution and also a very wealthy institution, okay, that sense of shame. So some examples of these struggles, and I might struggle as I read them, but students have delayed or foregone treatment and medication for severe COVID, bone fractures, a miscarriage, keep it together. Okay, mental health care, post-operative pain, chronic medical conditions, regular checkups, and more. In the summer of 2020, a student sustained injuries after being hit by a truck, but did not seek medical attention due to the costs, even with HMO insurance. They could not afford physical therapy and were in pain for months, in addition to experiencing psychological trauma. Some students who had no choice but to seek emergency medical attention, for example, for a life-threatening allergic reaction, a pulmonary embolism, have gone into debt upwards of $10,000 to $15,000, and one classmate I know after many years is still paying that off while still in the program. Because of her inadequate healthcare plan, one student delayed treatment after a miscarriage and laid in bed bleeding for 3 days before finally seeking care on the 5th day to make sure she was not at risk for death with an ectopic pregnancy. She incurred a $4,000 bill that she could not pay. Finally, an uninsured student who had severe respiratory symptoms from COVID walked himself to the ER in Philly because he couldn't afford an ambulance. After receiving a quote of $40,000 for treatment, he walked back to his apartment. He said, and I quote, "I walked out. I am so broke and so indebted that the idea of risking it alone in my apartment seemed like the financially healthier thing to do, even if existentially risky." End quote. I hope these stories sadden you, and not only because they are the stories of students right here on our own campus, but because they're also stories of suffering that could have been eased or prevented altogether. The sad truth is that graduate students take on significant risks by coming to Villanova, which raises important questions about diversity, equity, and inclusion. How do we, as a university, as a Catholic university, create the conditions that, for example, allow students from an economically disadvantaged background, students with pre-existing health conditions, or students who simply experience health emergencies, and we're all prone to that, to not merely survive Villanova, but to thrive here, or in the language of Catholic social teaching, to flourish. Thank you.
Thank you, Jennifer. She's given us, provided us a sliver, and it's just a sliver. There are many, many, many more stories like those of graduate student experience with healthcare at Villanova. And there's much more that might be said, but we have a hope, we hope you have a sense of the kinds of challenges our graduate students face. What I'd like to do now is identify two principles that ought to push Villanova University toward full and high-quality health care for at least the graduate students who are financially dependent on the university. So as you've heard several times, Villanova is an Augustinian Roman Catholic institution. It's a mission-driven institution of higher education. As any Villanova undergrad can attest, this identity does indeed mark the undergraduate educational experience. The same should be true of graduate education. Within the Catholic intellectual tradition, the principles of Catholic social thought that have been mentioned several times already today stand out as a powerful resource that can guide institutions, particularly those who espouse that tradition as an orienting force. It can guide them in how to operationalize the values of that tradition. So I want to talk about two. The first, Father Art mentioned the principle of the common good, and the second, that hasn't been mentioned yet today, the principle of participation. So the principle of the common good states that one ought to pursue social, economic, and political conditions that enable all people, as individuals and as groups, to have ready and thorough access to the means of human flourishing. So as Professor Davis pointed out, it's structural, and that's again been echoed throughout this day. The common good is a structural principle. It has us look at the structures of our society, not at individual actions, that's a distraction, but to look at the structures. The focus of this principle is on the conditions of a society that might hinder or enable the flourishing of its members. There is much that can be said about the various conditions necessary to make human flourishing most likely. But I think we can all agree, at least I hope, that access to health care is one such condition. It is difficult to imagine a person flourishing. Think about the stories that Jennifer just said. It's difficult to imagine a person flourishing if she can't access regular visits with her doctor, or is unable to adequately tend to a chronic condition, or who has to decide between food or medicine because of financial constraints, or who puts off taking care of a mild condition only to find the condition become more serious and so debilitating. Now, just a note on that. I wrote everything because if I just talked extemporaneously, I don't know what I would say. But as a note on that, I'm thinking about, just from an economics perspective, if you're just a business person, it makes no sense not to treat a mild condition, which is going to be way cheaper than addressing a chronic condition. As for the graduate students in particular, those who indeed are in need of high-quality health care, not having it, and so being able to adequately care for themselves, find themselves anxious, worried about how to tend to their health, but also pay the other bills confronting them, on top of writing a dissertation, teaching their classes, writing the papers for their professors. This kind of anxiety impacts their work, their quality of life, their family lives. It's an obstacle to the flourishing that the common good demands for all human beings. The other principle I want to hold up is the principle of participation. This principle speaks to the social character of humanity. All human beings, it says, have a right and a responsibility to be active members of their communities, at work, in school, in their neighborhoods. A primary Augustinian value is community. Community requires the active participation of all its members, not just a few. Again, the inability to access high-quality health care becomes an obstacle to full and active participation. Anxious cares, the need to protect one's health in an overly aggressive way, the need to find additional ways to meet one's expenses, the additional financial debt accrued over time, these all function to decrease the ability of a person to participate in her community. Removing the obstacle to access to full and high-quality health care serves to make possible the active participation that is the mark of the social creatures we are, made in God's image. Now, to Villanova's credit, there have been some moves in this area. The provost of the university has created a task force of high-level administrators who are examining graduate life at Villanova in all of its dimensions, including healthcare. In fact, this past summer, that group pushed for an expansion, an increase of the graduate student healthcare stipend from $1,000 to $1,500. So Jennifer mentioned $1,500, which it is right now, but that just happened. And for the first time, master's degree students who are already stipended by the university can apply for $500 stipend toward healthcare for themselves. So we're going in the right direction. However, as Jennifer has demonstrated for us, even on the ACA exchanges, those stipends are quite inadequate to the cost of healthcare, let alone quality healthcare. So while we are encouraged that Villanova is moving in the right direction on these issues, we have to urge the administration to consider the values that we espouse as an institution. It is not enough to say, Lord, Lord, if we're not putting it into action. And for those of you unfamiliar with that, that was a paraphrase of Jesus. If we're not going to put into the action the values that we so proudly proclaim as central to this institution, then we have to hold up a mirror and be very honest. I think we can, and I think we want to be. We not only because we want the best graduate students to come to Villanova, but because we're committed as an institution to a set of principles that challenge us to be better. So we urge this on our administration, not because it's the expedient thing to do. And it is expedient in terms of recruitment and retention of good students, but because it's the right thing to do for the common good of this great university. Thanks.